Hi, everyone. I'm Dr. Aaron Drucker. I'm a dermatologist in Toronto, in Canada, and I'm looking forward to speaking today about what's new in comorbidities for atopic dermatitis. Thanks to the International Eczema Council for arranging this talk. I have no relevant disclosures. The learning objectives today are to review the epidemiologic evidence for a few non-atopic comorbidities that are associated with atopic dermatitis. I'm specifying non-atopic because I'm going to leave things like asthma and hay fever, things that we know are associated with atopic dermatitis. We've known that for a long time. I'm leaving those out to focus on some other more novel associations. I'm going to spend some time hypothesizing pathogenic mechanisms underlying some of those comorbidities, and to integrate understanding of those comorbidities into clinical practice. Because it's one thing to find whether atopic dermatitis is associated with a given condition or not. It's another thing to understand how we can put that into practice, how we can operationalize it. So the first group of conditions are mental health conditions, and specifically depression. And there have been a large number of studies that have looked at the association between atopic dermatitis and depression. These are forest plots from a meta-analysis that looked at the association between atopic dermatitis in adults on the left and children on the right. And we can see for both, among both age groups, that there is an association between atopic dermatitis and depression, more pronounced in adults, but still present in children. In adults, more than twice the odds of having depression if you have atopic dermatitis compared to if you don't. So certainly a significant and important association. We also found, looking at data from my home province of Ontario, that atopic dermatitis eczema was associated with about a 22% increased risk of suicide in this case control study, and that about 2/3 of eczema patients who died from suicide had seen a physician in the 1 month prior to their death. Which suggests that we, as people who are caring for people with eczema, may have opportunities to intervene to prevent some of these bad outcomes. And furthermore, especially as dermatologists who are focused more on caring for people with more severe eczema, I think that point is even more pronounced, because we see that the association between eczema and depression and anxiety is even more accentuated, particularly for depression, among people with more severe eczema. So that all is, not very good news. But the good news about the association between eczema and depression, as well as anxiety, is that we can make a difference there. It's unclear whether the association between eczema and these different mental health outcomes is really a symptom of atopic dermatitis, that their skin disease is making them have a low mood or be more anxious, or if it's an independent association that people with eczema are more likely to have a mental health disorder occurring on its own that is not necessarily impacted by eczema symptoms. But what we do know is that if we treat people, particularly with more severe eczema, if we treat them effectively, in this case with these line graphs from an abrocitinib clinical trial, but I could have picked out graphs from any one of older or newer systemic agents for atopic dermatitis, we see that when you successfully treat eczema, that depressive symptoms improve. So while we may not be able to treat everyone with eczema's depression by treating their eczema, we certainly can make a difference for depressive symptoms by using effective treatment. So what are the clinical implications? I think the most important thing is to ask about and assess mood and sleep during clinic visits, because these are overall markers of disease severity and impact. And for many patients, low mood is a symptom of their atopic dermatitis rather than a primary mental health condition. So if we can successfully treat their skin disease, we can sometimes manage this comorbidity. But in many cases, that is not going to be the case if they do have a primary mental health condition, and then coordinating care with the primary care physician or specialty care in mental health with a psychologist or psychiatrist is going to be important. The next comorbidity that I'm going to discuss is group of comorbidities related to cardiovascular disease. So again, I'm starting with a meta-analysis here that found that atopic dermatitis was associated with small increased risks of angina, stroke, heart attacks. And I said that word small because these are all small increases in relative risk, 18%, 17%, 12%. Even though these are statistically significant, these are not large effects that atopic dermatitis seems to be having on the risk of these different cardiovascular outcomes. What's interesting is just like what we saw with depression is that the risk does seem to be modulated by eczema severity. And so people who have more severe eczema have a further increased risk compared to people with moderate and mild eczema of these different cardiovascular outcomes. Again, this is from the same meta-analysis that was able to tease out eczema severity in the studies from which it was available. So why might atopic dermatitis be associated with cardiovascular risk? Well, there are a number of potential reasons. First of all, is it through all these different mediators of other things that have been associated with atopic dermatitis, things like sleep disruption, depression, the use of oral steroids, smoking, obesity, various conditions that have in other studies been associated themselves with atopic dermatitis. Could it be different confounding factors like a history of asthma? We know eczema is associated with asthma, and asthma associated with cardiovascular disease. Same thing with socioeconomic status and ethnicity. These could all be, causing a false association between atopic dermatitis and cardiovascular disease. And then in the middle, this big red wording with the question marks is inflammation. Is there a primary inflammation in atopic dermatitis that increases cardiovascular risk? And I think there's been more and more evidence coming out to date that inflammatory hypothesis is something to think more about. I don't think it's really been proven, but there have been a number of different studies using cardiovascular markers and imaging and in the blood that have shown that people with eczema have increased signs of cardiovascular risk systemically. So it certainly is possible that the inflammation of eczema does contribute to cardiovascular risk, just like we've learned about for psoriasis. But I still don't think there is enough actionable evidence for us to really have any clinical take-homes with regards to the association between eczema and cardiovascular risk. The absolute risk is really low. Absolute risk difference per 100,000 person years is given in this table here, and these are all very small numbers. The implications here are that for people who have atopic dermatitis, they should have whatever age-appropriate screening and preventive measures are indicated, independent of their atopic dermatitis. That their atopic dermatitis shouldn't necessarily change what we as clinicians do in terms of cardiovascular screening. Of course, anyone who is a smoker or who is overweight should be counseled on those lifestyle factors, but we should be doing that for anyone who has those issues, regardless of whether they have eczema or not. And furthermore, even though, as I said, there is some hypothesis generating evidence that the inflammation of eczema may be involved in cardiovascular risk, there's really no evidence to date suggesting that treating atopic dermatitis has any impact on cardiovascular risk, treating that inflammation. The last group of comorbidities that I'm going to talk about are autoimmune conditions. And in this really nice study from a group of Denmark, they looked at the association between atopic dermatitis and a whole wide range of autoimmune conditions. And they found that there was a really large association between atopic dermatitis and these conditions, having one autoimmune comorbidity, two autoimmune comorbidities, or three or more autoimmune comorbidities. We very rarely see odds ratios up above 5. So this is a pretty substantial association, not in the range of a relative risk of 1.12 and that sort of thing like we saw for cardiovascular disease. And this is the list of autoimmune comorbidities that this group studied. And everything that I've highlighted in orange are conditions where they found a positive association with atopic dermatitis. So not every single autoimmune condition was associated with atopic dermatitis, but a large number were, including skin conditions that we're familiar with, as well as a number of other systemic autoimmune conditions that we don't necessarily think of as being related to atopic dermatitis. And why might this be? It's certainly possible that this is related to the underlying genetics of the condition. There are many immune-related genes that have been associated with atopic dermatitis, and those in turn have been associated with a number of other autoimmune comorbidities as well. We often think of atopic dermatitis genetics as being mostly related to skin barrier proteins, but there are also many findings that have been associated with different immune-related genes. And I think the clinical implications here are very interesting, particularly as we have more and more targeted systemic therapies approved. I don't think there's any screening necessary. You don't need to screen your patients who have atopic dermatitis for any number of different autoimmune comorbidities. But if they have known autoimmune comorbidities, we can use that to tailor our treatment. So recently we've had a number of newly approved Janus kinase inhibitors, JAK inhibitors, and these have, in addition to being used to treat atopic dermatitis, have been used to treat alopecia areata, which is what this graph on the left is from a trial of baricitinib for alopecia areata. Also for things like inflammatory bowel disease. On the right here, you see figures from a publication showing that upadacitinib works for ulcerative colitis. And these medications have been approved for a number of other conditions. We know that some of the biologics also have multiple indications. So I'm hopeful that in the coming years, we'll be able to create a publication like this one that was made for psoriasis, which therapy for which patient, focusing on comorbidities. We'll be able to pick and choose our targeted therapy for atopic dermatitis in order to improve not just their skin disease, but other associated autoimmune conditions as well. So in summary, atopic dermatitis is strongly associated with mental health comorbidities, and we can help to alleviate some of those symptoms. But if there's a primary mental health condition as well, then we're going to need to coordinate that with family physician or mental health care workers. In terms of cardiovascular risk, we don't need to be screening or treating atopic dermatitis with a focus on cardiovascular risk at this point. And with regards to autoimmune conditions, there are potential therapeutic implications. If you're interested in reading more about these and other comorbidities, we just had a new publication as part of the AAD's guideline, the American Academy of Dermatology's guideline series on comorbidities that just came out in January of 2022. So that's an excellent resource if you're looking to learn more. Thanks again for your time today. I was happy to speak about comorbidities and hope it was helpful. My Twitter handle is here in case anyone wants to get in touch, has any questions. Take care.